Welcome to the Dr. Bergson's Best Health Radio Show. You know, we used to worry about the big C, cancer. Now we all seem to worry about another big C, which is cognitive decline. We all want to live longer, but we really want to keep our wits and our memories with us. How precious is that? Our guest tonight is a neurologist, a famous medical doctor that's really shaking the shoulders of medicine to tell us exactly how to do this. This is Dr. Dale Breseden's second time on this show. I'm going to give you a little bit about his background, and then we're going to jump in because he's got a brand new book called The End of Alzheimer's Program. He's an internationally recognized expert in the mechanisms of how the brain goes south, neurodegenerative diseases. And he's really built his career on a simple idea that Alzheimer's, as we know it, is not just preventable but reversible. I was just at a neurologic conference, and these PhDs and MDs were standing on the stage and saying that there's nothing to be done for Alzheimer's. And our guest today has the exact answer and can explain why that's not true. Now, he got his medical degree from Duke University Medical Center, and I just got to tell you some of his things. I know you want to hear them, but he served as chief resident in neurology at the University of California before joining Nobel laureate Stanley Prusner's laboratory at UCSF with the National Institute of Health postdoctoral fellow. He held faculty positions at all these acronyms: UCFF, UCLA, the University of California, San Diego. He's also directed the program on aging at the Bernheim Institute before joining the Buck Institute in 1998 as the founding president and CEO. That's very prestigious. So his research really explores uncharted territory in the brain, explaining the physical mechanisms by how we erode our memory, but how we get it back. Welcome to the show, Dr. Dale Breseden. So excited to have you back about your new book.
Thanks very much, Dr. Bergson. Great to be here.
So tell us a little bit, why am I still hearing from so many people that there's no cure for Alzheimer's when you've been publishing in peer review, reversing it in patients?
It's a great point. And, and we don't call it a cure because for that you would want to have an autopsy, and you'd want to look to see that there are no plaques there, et cetera. What we say is reversal of cognitive decline. And we've seen that now and published it in over 100 patients, seen it in hundreds and hundreds. We're still getting, nearly every day, wonderful stories. And we are in the midst of the first clinical trial in history that does something completely different than all previous clinical trials for cognitive decline. So here's the way it works. All previous trials, as you know, predetermine a treatment, which actually makes no sense. So you say ahead of time, okay, no matter what's causing your problem, we're going to give you drug A or drug B, or we're going to give you, exercise or something. In our case, what we're doing is we are determining during the study for each person what is causing the problem. And it's typically 10 to 25 different contributors. So people, as you know, will have insulin resistance. They'll have some mild neuroinflammation. They'll have a leaky gut. They'll have specific pathogens that need to be identified. They'll have specific toxin exposures that need to be identified. And then we use a precision medicine algorithm that we developed that targets each of those things. So as you can imagine, each person is treated somewhat differently. And this is the way of the future. And so we're in the middle of this. This will finish in December, will be published next year. Very excited about this. But meanwhile, we continue to use the protocol that I first published back in 2014. And just as you said, it is reversing cognitive decline in person after person after person. And yet, again yesterday, a professor from Columbia came out and said, well, there's just nothing we can do. And in fact, he went farther. He said, by the time you have the first symptoms, it's way too late to do anything. Well, that's absolutely wrong. We see it. In fact, we encourage people, please, if you don't get on prevention, please get in with your first changes, because it's so much easier to improve things during that time than waiting until things are very, very late.
You've developed a cognoscopy, right? Some kind of a program that evaluates where your cognition is at. Can you explain that?
Absolutely. So again, human beings, as you know, they're complicated. This idea that we're going to tell you have Alzheimer's, which means that's just someone's name, it doesn't mean anything. It's like telling someone that when they bring their car in, you have car not working syndrome. I mean, that doesn't really help you. It doesn't tell you what's causing it. So you need to ask, what is causing the problem? And so what a cognoscopy is, very simply, when we all know when we turn 50, what do? We go and get a colonoscopy. And actually, my wife and I went together on Valentine's Day, and we had his and hers.
So a romantic colonoscopy.
We just thought, we got to get it done. So we both went in together and had his and hers colonoscopies, and all good. So we were very happy then to go out to dinner together. So the bottom line is, we all know we got to have a colonoscopy when we turn 50. Well, if we're 45 or over, we should have a cognoscopy, because you don't want to ignore that end of the being, right? You want to make sure your brain is doing well. And in fact, there are many things that are critical for cognitive decline. So you want to know what your HSCRP is. You want to know what your fasting insulin, what your HOMA-IR is, on and on and on. And all these things are easily checkable. So a cognoscopy consists of 3 simple things. Number 1, a series of blood tests. Pretty straightforward. And you can get this actually directly online at mycognoscopy.com. Easy to do. Second thing, you want to have a simple online cognitive assessment. If you're having trouble with your memory, if you're having trouble with your executive function, if you're having trouble with naming or word finding, you can test that easily online. It takes about 20 minutes, easy to do. So that's the second part of the cognoscopy. And the third part is optional if you are asymptomatic. So if you don't have any symptoms, you're just there for prevention and you're doing well on the cognitive testing, great, you don't need an MRI. But if you're already scoring poorly on the testing, or if you have complaints, you're saying, my memory's just not what it used to be, then you want to include an MRI with volumetrics. You want to know if you have any hippocampal atrophy, for example.
Please explain that. The shrinkage of your hippocampus, explain what that anatomical little cute but very critical area is.
Yes. So a hippocampus is an area of the brain that's actually shaped like a seahorse, which is why it's called hippocampus. That's from the French hippocamp, which is seahorse. And it is critical for memory, and especially forming new memory and memory consolidation. And it is one of the earliest areas, along with the entorhinal cortex, to be affected in Alzheimer's disease. And so you begin to see some atrophy of this. And if you've begun to have atrophy, then in fact, we'd like to know it. Now, excitingly, we have seen a number of people where we can document their hippocampal now increase in volume again when they get on the protocol and do the right things, because you're now supporting memory formation. What we've discovered in 30 years in the lab is straightforward, that basically there is this beautiful balance between synapse formation and maintenance, literally making and storing memories, versus synaptoclastic activity, pulling back. And of course, this is happening every day. You're actively forgetting the 7th song that played on the radio on the way to work yesterday and things like that. So this is a normal and beautiful balance, just as you have, for example, in your bones. You have osteoblastic activity and osteoblasts making bone. You have osteoclasts picking up the bone. And when you're young, there's a beautiful balance there, and you're always strengthening your bone. Now, as you get older, you may begin to have osteoporosis because your osteoblastic activity is now chronically exceeded by your osteoclastic activity. We found the same thing happens with Alzheimer's. There is synaptoblastic signaling, and it has to do with your hormone status, and it has to do with your nutrient status and your growth factor status and your sleep status and your stress status, and on and on and on. Then there's a separate side which is the synaptoclastic side, pulling back. And you're continually doing this, and you're only keeping the most important things that you're learning, such as how to drive, how to do your job, how to speak, how to calculate, all that. Now, what happens is, if you are exposed to things that are toxic, for example, or pathogens, then you get on the wrong side, too much synaptoclastic activity for the amount of synaptoblastic activity. So literally, Alzheimer's is synaptoporosis, essentially. And so all we do is we measure the many different things that are contributing to each of those. And for treatment, of course, we want to increase your synaptoblastic activity and decrease your synaptoclastic activity. So you now are on the right side of that balance, and you are able to make and store memories once again. And we see it again and again and again. This comes from biochemistry from 30 years in the laboratory. And this idea that, we're going to try to sweep away the amyloid and that's going to make things better is ridiculously overly simplistic. And the studies have shown that. It has not worked time and time again in clinical trials. So unfortunately, the current standard of care is to tell you there's nothing that can be done. It's because they're not doing the right things. So you need to measure the right things. You need to address the right things. And that's the way to get the best outcomes.
Talking about measuring, when you're doing the MRI, do you need contrast to evaluate the hippocampal volume?
Absolutely not. No,
okay,
in fact,
that's
you typically
cool.
do it's great. So you can stay away from the contrast. That's a good point.
So I often refer to the hippocampus as the physical analogy of our soul, because sense of orientation, motivation, memory all lives there. And I do a lot in the work with hormones, and there's so many receptors there. And I know that McGill University has shown some reversal of hippocampal atrophy with giving elderly people, women estrogen, and men testosterone. So part of your pillars, one of them is looking at hormonal robustness or lack of it, right?
Absolutely. And you can think of this as a complex system where, yes, or let's say an orchestra, you want to make sure that you got enough violins, they're playing the right way, the people are skilled at playing them. You want to make sure that the timpani are doing well. You want to make sure that each of the instruments is tuned appropriately. When you get everything playing together, it sounds wonderful. Now, when you've got everybody doing the wrong things, you can't just say, okay, now I'm just going to add one violin. Well, wait a minute. Is it the right thing to add? Were you really low on violins? Can this guy play, or can this woman play the violin? So it's a little more complicated than just saying, let's just take the amyloid away. It's kind of silly, actually. So, same idea, absolutely. And as you pointed out, you can actually see the hippocampus enlarge once again. And they've done this with things like exercise has been shown to increase hippocampal volume. You mentioned the hormones, absolutely. And with our protocol, we see the exact same thing, because now we're giving all the things that allow you to say, okay, I'm in good shape. Your brain, when you make this amyloid that is associated with Alzheimer's, the big surprise has been it is actually a protective factor. It's actually something that is killing microbes, as Professor Rudy Tanzi and Robert Moyer from Harvard showed a number of years ago. This is responding. So our point
kind of
is
like cholesterol. It ended up being that it's really dealing with eddy currents and disruption in the endothelial quality. It's not really the cholesterol that's the big bad guy.
That's exactly right. So this is a response to insults. So we want to identify the insults, we want to correct the insults, and then we want to help you become resilient and rebuild. And by the way, this is very similar to what's going on with COVID-19. Many of the same factors, diabetes, obesity, hypertension, all of these things, which are concerns over decades in Alzheimer's, are now compressed into 2 weeks with COVID-19. So many of the same risk factors.
That's so interesting. I was going to ask you, because COVID has been also termed a vasculotropic illness, because it really damages the lining or the endothelial lining of blood vessels and travels throughout the body, and apparently can cross the blood-brain barrier where there's a lot of neurologic issues. And I was wondering if you could comment. This is a perfect little tie-in with that.
Absolutely. And there are a number of papers now already out on people studying the COVID-19 neurological sequelae. And of course, in the acute phase, the big one is stroke, as you indicated. It is a vasculopathy, and unfortunately, even young people with large vessel occlusions. So really unfortunate. And yet another reason to please, everybody, stay safe, take care, because that can be a major problem. Then in addition to that, encephalopathy, seizures, Guillain-Barré syndrome, where you get paralysis, brainstem effects, of course, a common one, loss of sense of smell, anosmia, ageusia, loss of sense of taste, all of these things. Now, the big concern, these are all acute changes. As you now get better, the big concern is, are we going to have people with a greater likelihood of neurodegenerative disease in the future? Parkinson's, Alzheimer's, frontotemporal dementia, ALS, because of effects with COVID. Everyone's concerned because of what happened a century ago with post-encephalitic Parkinson's, people who had encephalitis, von Economo's encephalitis back in the 19-teens and 20s. Many went on to develop Parkinson's later on because of that virus and the follow-up. So now the question is COVID-19 going to cause this? On the positive side, we don't see as much acute neurological damage as was described when people had the von Economo's encephalitis. So that's the good news. On the negative side, as you indicated, there's already a lot of evidence that it can impact the brain. You can even find it in the cerebrospinal fluid. You can even have acute encephalitis from COVID, although that's not very common. The big one, as you said, is stroke. So we kind of have to hold our breath and hope that people don't develop post-COVID neurodegenerative diseases.
Boy, one thing I want to just do about tracking back a little bit to the beginning, I'm very much blown away that you're doing this peer review randomized trial, but you're doing it in a functional medicine way where you're individualizing each patient so I was wondering how you're bringing controls for each patient or how you're working that out. But that is brilliant. I've never heard of anyone doing that before. And just to accomplish that and to really take a look at the root cause of each patient and yet put it in a large trial. So can you explain a little bit more about the design and the methodology of your trial, how you accomplished that? That's huge. It's absolutely, I actually was sitting on the edge of my seat when you started to describe that.
That's such an important question because this comes back to how do we change the way we think about and practice medicine? What happened is in the 20th century, we all got used to writing a prescription. It's a monotherapy for seizures, for headaches, for hypertension, for all these things. Now in the 21st century with precision medicine, we understand human bodies are much more complicated than that. And unfortunately, we are now all dying of complex chronic illnesses. It's not pneumococcal pneumonia where you just write a prescription for penicillin. So we have to look at all these different variables. We look at, with the Cognoscopy, we look at dozens and dozens and dozens of different variables because these are the things that are driving the decline. And that, of course, allows us to do much better with prevention, much better with reversal than has ever been done before. So starting back in 2011, we requested that the IRB, the Institutional Review Board, allow us to perform the first comprehensive trial for cognitive decline, both for MCI, which is mild cognitive impairment, which is the pre-Alzheimer's, and for Alzheimer's. We were turned down in 2011 because they said, it's too complicated, you're doing too many different things. Well, the problem is
they always want to constrict you, but that's the opposite of the way the body works. Yeah.
And this is, so you're absolutely right. This is a huge fight because medicine must change. The idea of watching person after person after person die of Alzheimer's just because, we want to just do one variable, it just makes no sense. And in fact, we need to recognize that these are complex chronic illnesses. And this is true, of course, functional medicine. This is also precision medicine. attacking the things that are actually causing the problem. And, it's so interesting to me. Google knows where you shop. Google knows what your life is like. Google could probably tell you things that you would be so surprised that they know about you. And they use complex algorithms to determine all these things. Why are we not using the same sorts of high-tech approaches to help people who are dying of neurodegenerative diseases? In fact, neurodegeneration is the area of greatest biomedical therapeutic failure. If you have Alzheimer's, if you have ALS, if you have Parkinson's, these things are things that have not been improved. You get a little symptomatic improvement, yes, with Parkinson's, but it doesn't change the process. So what we did, we got turned down in 2011. We then went, and that's when we started then to do, at least anecdotally, so hey, let's get more data. Let's show that we can actually do this in person after person after person. That's been very helpful. We've learned a lot. We published initially 10 who improved in 2014. We published another 10 in 2016. And then 2018, we published 100 people who have documented improvement, objective documented improvement. In some cases, their MRIs, in all of the cases with their cognition. So we can use things like MoCA scores or MMSE scores or SLUM scores or CNS vital signs, which is a very nice and sensitive way to do this, and showed improvement in all of them, which is not to say every single person responds. We're not there yet, but we have unprecedented improvements. So finally, we got turned down again in 2018 for the trial. And then luckily, finally in 2019, we were approved for the trial. Now, here's the part that's important. You mentioned the control group. So the controls must be, at the beginning, must be historical control. So luckily, there's been so much that has been studied about what happens with people with cognitive decline. They don't get better, as you know. So there's a very good statistical association of how quickly people go downhill. And that's been used with other papers. You may have seen the paper from Dr. Isaacson recently, who's interested in prevention, and they used historical controls. This is what would likely have happened if we hadn't done anything. So we're doing the same thing with this. So people absolutely, each one gets on a precision medicine protocol. We attack whatever toxins they have, whatever pathogens they have. We make sure that they become insulin sensitive. We bring them into mild ketosis. We have them exercise. We have them do brain training. So they are doing all the things that literally changes the neurochemistry from a synaptoclastic neurochemistry, a pullback neurochemistry, to a synaptoblastic neurochemistry, a go forward, make connections. And we're seeing it again and again and again. And we're getting all sorts of wonderful reports from people not on the study who are getting better. So we look forward to publishing this study next year. Very excited about it. We'll see how it goes.
That's very exciting. And is it true also that you've trained quite a number of doctors that are going out and also using your protocols on their patients?
Great point. So we've trained 1,500 physicians from 10 different countries and all over the U.S. Now, some of them are doing it and some of them are doing, changes in it that sometimes don't work. So you have to be very careful. This is not simple to do. As you know, functional medicine is about a lot of genetics and biochemistry and getting it right for people. You have to learn functional medicine. You have to learn precision medicine. So we do have a new training for what we call Recode 2.0, Recode being reversal of cognitive decline, 2.0 that's going to come out in late July or early August. And we've got some absolutely fantastic teachers involved with this as well. Dr. Neil Nathan, who's a world expert on biotoxins.
He's
Dr.
been on the
Chris,
show here. Yes.
Oh, fantastic. And he's absolutely great and getting tremendous results. Dr. Chris Shade, who's an expert in chemotoxins. And you know Chris. And then Dr. Cyrus Raji, who's really the expert on neuroimaging in these changes and this neuroimaging with functional medicine. Cyrus has published a lot and is currently at Washington University in St. Louis. And then others, Anne Hathaway, who's an expert in bioidentical hormone replacement and fantastic physician. So we've really got some luminaries to help with this teaching and to talk about their own areas of expertise. So I'm really excited about that.
Can you give us a little bit of a synopsis of your brand new book and why this book came out and how it's different from your first book, which was The End of Alzheimer's, that was on the New York Times bestseller list? And I mean, it's like a Bible to so many physicians that I know.
Thanks very much. Yeah, it's out in 32 different languages right now, so I'm really enthusiastic about that. So what happened when we published the first book, the whole idea was, here's the first book to say, hey, here are people getting better. Here's how we looked at this in the laboratory. Here's how we translated it from the laboratory into daily human use. And we had a lot of comments. One was, and a common one was, hey, we want more details. Where do we go? What website do we use? What do we do when we shop? What is it really important to do this particular detoxification agent or that one? How can I do this for my family? So forth and so on. How can we prevent this in our children? So all these details. So what we did was the second one is really the program. So this is the detail. The first one was really about the science and how does it work and why are we claiming that we can actually see reversal and how do we document that and things like that. So the second one is to add in all of the program. And what I'm really most excited about is I worked with two very complementary people. One, Julie G., who's the one who founded ApoE4.info. Now, she is an ApoE44 patient herself who developed cognitive decline, got on the program. She's now been on it for 8 years. She's doing absolutely great. She's scoring repeatedly 98th, 99th percentile in her cognitive tests. She had gotten down to the mid-30s. And she's doing absolutely great. So she is a daily user. She's got great workarounds. Here's how you do this. Here's what worked best for me. Here's what worked less well for me. Here's a brand that worked better than that brand. All of the tricks of the trade of someone who's doing this every day, very complementary to my own scientific background. And then my wife, Dr. Aida Lusheen Bredesen, who is a clinician. So we have a clinician, a scientist, and a user. And with that, we really have a
sounds like a joke.
Yeah,
We're
really.
going to have a joke like, okay, I'll stop.
Yeah, really. Okay. So yeah, exactly. But in any case, what I liked about it is it really gave us a triad of very complementary skill sets. And so we have a handbook in there. Here's a handbook on what to do with step-by-step guidance. So we're really enthusiastic about that. It'll be out August 18th from Random House.
That is totally exciting. This is a must-have book because we all have to protect our brains, and the aging starts earlier than our chronological age, and you really want to be on top of it. And can you give a few patient examples so that people can grasp this and understand the importance that they should own both of your books, because you really talk about the care and feeding of the brain like no other physician has been able to pull together up till now?
Thanks very much. We're so excited to see the translation of the science. And first, let me just mention, before going into the stories, one of the things that's come out from people who see patients with cognitive decline is they're seeing a tick up with COVID-19, not because of the virus itself, but because people are staying indoors. They're more depressed. They're more anxious. They're more stressed. They're exposed to more mycotoxins. All of these things are contributing to a tick up in cognitive decline. So we really want to get people to be on prevention. Huge issue. Get out there. It's turning out that indoors is more dangerous than we thought it was. For the last few years, people have been saying, sitting is the new smoking. Well, it turns out, indoors is the newer smoking, because in fact, that's where the mycotoxins are. That's where the off-gassing is. All these things. Getting out there. Same
just have
sort
to
of
make
COVID.
one little comment. Don't mean to interrupt you, but the EPA did a 10-year trial. They were called the team studies, where they put monitors on a representative population, about 3,500 people, and monitored where they got their biggest polluting exposure. And it turned out the bad and good news was that it was in the home. So what you're saying is we're all staying there because we need to stay home, but there's problems with staying home.
That's a great point. And in Wuhan, they looked at where the transmission occurred. And what they found was that in all but one of the cases that they studied, it was indoors. That's where 6 feet indoors is not enough, because you've got the recirculation, you've got the ductwork, all these things. You've got the air conditioning. Whereas outdoors, you've got the dissipative environment. So now it's not such a big deal. You can distance more easily outdoors as well. And so what's happened with this big tick up recently from Florida, from Texas, Texas, from California, unfortunately, reopening, people going back. And you heard about that group of 16 in Florida that went to the bar and all got infected. So yeah, outdoors is where it's at. So a couple of quick stories. We have a just example after example. I have to say, these are the most heartwarming stories I've ever heard during my career, because I was taught that there was absolutely nothing to do about neurodegenerative disease. So, and we have a book coming out next year that's called The First Survivors of Alzheimer's. And these are first-person stories from these wonderful people. And so there's a woman in South Carolina who came in, had an amyloid positive scan, ApoE4 positive, so she had the risk factor. She was scoring relatively poorly on her MoCA score and clearly had early Alzheimer's, actually went on a clinical trial, which made her worse. And so she stopped the clinical trial after a couple of months because she said, every time I get this, it was an injection. Every time I get the injection, I clearly get worse. So she then went on the protocol. She now has a perfect MoCA score. She's doing absolutely great. And we talk a little bit about her in the book. So very, very exciting to see. And she sends me cards every now and then. She and her husband go kayaking. She's just an amazing and wonderful, wonderful woman. She's now late 60s, and she's really started her problems in her late 50s. So it's been quite a while.
Do you remember at all what her several major root cause issues were that you reversed?
Yes. In her case, it's interesting. In her case, she had almost every one of the risk factors. So she clearly had mycotoxin exposure.
Can you explain what that is a little bit if someone's not sure?
Yeah. And so, this is a really good point, because mycotoxins are turning out to be both very common as a cause of Alzheimer's and one of the most difficult things to remove, because you have to get rid of the things that are producing this. So what happens is, when we live in our homes, unfortunately, our homes are built out of mold food. The stuff that mold likes to eat is what we build our house out of, wood, many times. And so what happens is, if you have water intrusion, so these are water-damaged homes, which happens in somewhere around 50 to 60% of buildings around the U.S. Now, fortunately, there are some molds that don't make these toxins. So there are the big five bad guys that you really want to know about. Do you have Stachybotrys, Penicillium, Aspergillus, Chaetomium, Wallemia? Those are the big five bad guys, and they're the ones that happen to make toxins. And why do they make these things? Well, because they are fighting for their own survival. That's, of course, why we have penicillin, because Penicillium makes penicillin so that it, as a mold, can compete successfully against a faster-growing organism, which is bacteria. Now, if they're just sitting there and they're both not hurting each other, the bacteria are going to win out. They just overrun because they make more bacteria so much faster. So the strategy of the mold is, okay, I'm going to shoot some poison into these guys and they are going to die and I'm going to be able to survive. And that's what the mold has done. Now, unfortunately, although penicillin is not a bad one for humans, these other ones, trichothecenes, ochratoxin A, zearalenone, mycophenolic acid, and others. These things are toxic to humans. So in their evolutionary fight for survival, they are killing us, unfortunately. And most of us don't realize it because this stuff accumulates over years. And then what we have, and I'll give you an example, there's another woman who had years and years of exposure. And her husband has just been so fantastic, and she's been so fantastic. Once they realized, we said, look, we've got to look at all these things to see what's causing your problem. She had major exposure because of molds in their home to multiple of these toxins. And as these things have come down, someone that I was afraid was not going to do well because she was very affected when she started, she's turned the corner and she's improving. And her family members are commenting on it and say, wow, she's more engaged, she's more with it, which is really, really exciting to see. I didn't want to ignore your earlier question. The first woman, what else did she have? So she also had things like some insulin resistance, common. She had decrease in hormones, common. So many of us, that is a contributor. As you indicated earlier, decrease in some nutrients, vitamin D, decrease in some of the trophic factors. So all of these things, again, are part of optimizing your brain's ability to make and keep synapses. And, again, this is not magic, it's biochemistry. When you get on the right things, when you do the right things, you begin to see people turn the corner. And no surprise, when they don't do the right things, they don't turn the corner. And our patient Zero, who started way back in 2012 and has done so well, 4 times she went off the program. She ran out of some things. She was traveling overseas one time. She got a viral illness one time. She stopped. Within 7 to 10 days, she began to decline once again. And so absolutely crucial. You want to keep that neurochemistry on the right side of the balance.
Now, you talked about going somewhat ketogenic in your diet.
Yes.
What if you have a patient that has renal issues and they have to really minimize their protein intake? How do you accomplish that? Because a lot of people, as they age, start getting also kidney decline. How do you balance that out?
Yeah, you bring up such a good point. So again, we just go back to the neurochemistry. There are different ways to get ketosis. And why do you want ketosis? Well, because the brain, part of the problem with Alzheimer's is an energy insufficiency. Your mitochondria are not functioning as well as they should, and that's part of this. But also, you're not delivering the substrates that need to be oxidized, that need to be burned to get the energy. And as you know, you can see that on a PET scan. You do a fluorodeoxyglucose PET scan, what do you see? 2 L's. You see temporal and parietal reduced utilization of glucose. And as
so the brain is starving, it can't eat.
Absolutely. That's one of the overall problems. So what you can do now is supply that extra energy, bridge the energy gap with ketones. Ketones are burned beautifully by the brain as energy, and they give you that energy that you need. Now, you can get your ketones, yes, as you indicated, the best way to get them is endogenously. You make them by burning your own fat. But you don't have to do that. And as Dr. Mary Newport showed years ago, you can do it by taking things like MCT oil or coconut oil. And there are some wonderful exogenous ketones, such as Perfect Keto and Ketone A. There's a new one, KE1, KE4, things like that can give you those ketones. So what we usually recommend to people is start out, just take the ketones because you got an emergency there. You've not got enough energy. Help bump that up. You'll feel better, you'll do better, you'll have more energy, and your memory will begin to improve. Then, once you've stopped the problem, now over time, you can help get yourself into ketosis. Now, you're right. For someone who can't have the protein, okay, maybe you stay on the exogenous ketones. Again, there are workarounds. The key is the end stage, which is the end point of getting the right neurochemistry to get the best results. You don't necessarily have to do it. Now, there are some people that like to eat meat. There are some people that want to be vegan. Great. Vegan specifically good for people who have a vascular component, and that is one of the subtypes. But there's nothing wrong. Fish, wonderful. And I should mention, while I'm on the topic of fish, one of the most common deficiencies in the United States is choline deficiency. We should be getting about 550 milligrams per day of choline. If you're a woman, at least 450 milligrams per day of choline. Most of us.
Question.
Yes.
So what do you do if you go to the Cleveland Heart Clinic and you get your trimethylamine N oxide, your TMAO run, and you have very elevated TMAO, and it might not necessarily only be from gut dysbiosis, but it could also be because the enzyme that makes it is upregulated. I'm a DES daughter, and it turns out that exposure to endocrine disrupting compounds in the womb upregulate FMO3, the enzyme that makes it. So what do you do if you need choline, but you make this nasty molecule when you have more choline in you? That's a problem that I really would love to hear your answer to.
Yeah, that's a really good point. So again, we face the same thing with the LDL
balance.
Particle number. You are balancing. That's the human body.
I know.
Now what happens to your TMAO if you take citicholine, for example?
I really, my TMAO was so elevated when I first ran it. It frightened me so I've gone off everything, and I have tried citicholine because it's very helpful for glaucoma, and everyone in my family has glaucoma. You get older, you get so many things, you get so complex, but I haven't tried it. Do you think I should try citicholine and then retest myself?
Absolutely. Yeah, I think that's one thing to do. Check acetylcholine. You can even start low, start 250 milligrams a day, and then later it can go up to 250 twice a day, or even a little more than that, and recheck your TMAO and see if that's a problem. And of course, as you know, a big issue with meat, going off meat, as you pointed out, vegetarians don't typically get those high TMAOs. On the other hand, if you're already a vegetarian and this is purely genetic, then you're right. You're going to have to tweak your biochemistry to make it so that you do get the choline that you need, because you've got to have your acetylcholine, for your brain. The other thing you could do is say, okay, I am a little bit choline challenged. So what I'm going to do is I'm going to keep my own acetylcholine around a little longer by taking a little bit of huperzine A. You could do that as well.
Okay.
But again, now we're getting into things that are more pharmaceutical. So again, you want to do these things as upstream and as physiologically relevant as possible, as you know. But so many doctors don't do that. They just want to jump on that prescription pad and move on to the next patient.
Lost it. It's just so
really
lost it. So I work part-time in Naples at Dr. Perlmutter's old clinic.
Oh, fantastic. Yeah.
And I haven't flown there for a little bit because of COVID, because I'm in Texas, they're in Florida, and I'm older, and it's just too risky right at the moment. But we have a huge hyperbaric oxygen chamber. We have like 6 chambers that look like little submarine ships. Do you utilize hyperbaric oxygen in your protocols?
I'm glad you brought that up. Of course, that has been particularly helpful for traumatic brain injury, and particularly helpful for people who have a vascular component. But what we've been doing recently, because hyperbaric, as you know, it can be expensive for people over time, although it can also be very helpful depending on what the issue is. We've been suggesting a lot of EWAT, exercise with oxygen therapy, which does many of the same things without some of the expense of the hyperbaric. Again, I've never seen, and I don't think there is published, a direct head-to-head comparison between EWAT and HBOT, those two. I would love to see that. But I do think that one of the biggest problems we see in the people with cognitive decline is a lack of perfusion with appropriately oxygenated hemoglobin. And we see that in a couple of different ways. We see it because people have nocturnal desaturation. Of course, the tip of the iceberg for that is sleep apnea. But even people who don't have sleep apnea often are not getting themselves enough saturated oxygen, saturated hemoglobin with oxygen at night.
Now, how do you know that? How do you check that?
Very simply, you can check it with an oximeter. And you can actually do this on your own, buy an oximeter, even if you're not a doctor. There's one, for example, Better, BEDDR. I'm not involved with that group, but they have a very good one. And by the way, in the new book, we go through all these things about where to buy them, how much they are, what's better than another one.
You got to get this book. Do you hear this? You got to tell everybody get this book, because this is about keeping who you are alive. Exactly. You got to get these books, 2 books. His other book, The End of Alzheimer's, and his brand new book, and the name is The Alzheimer's Program. Is that it? Do I have it right?
It's the same as the old book plus program. So it's the program to go with. Right. Yeah, I was concerned when they first named it that, because I was concerned it sounded like the end of the program. But it's not. It's the end of Alzheimer's. It's the program that goes with that. And so, we do find that people have poor oxygenation at night. And then during the day, if people have vascular problems, we want to make sure that they get exercise with oxygen, which is why we like EWAT or HBOT, your pick, because you are now getting that appropriate support. This is about support for your brain. And you'd be surprised at how many people don't have enough trophic support, enough hormonal support, enough nutrient support, enough oxygenation, enough blood flow. All of these things add together. Again, coming back to the concert analogy, all of these are part of your symphony, your symphony orchestra, to get yourself enough support for these things. So that's a critical thing that we find again and again to be suboptimal. Another one, oral health. It's turning out that many people with cognitive decline have oral pathogens. So the oral microbiome is very important, just like the gut microbiome.
Your gut starts in your sinuses and in your mouth. You have biomes everywhere that cross-communicate. Yeah.
That's exactly right. And so if
you're so wise, I got to ask you, I know you're going down that path, but I'm sitting here and it's pounding in my head. How did you, starting out as a classical neurologist, I mean, what you're looking at is you are combining the best of functional medicine, you're calling it precision medicine, and you're taking it to a galaxy, a terrain where no one worked. How did you end up going from where you were to this? Because when you speak, you're so integrative and so amazing and so based in science. You're putting everything together. You're really extraordinary. Your work is so extraordinary. It's true. So I just, how did that happen?
So, this came literally from the test tube. So we started so simply by saying, could we understand the fundamental nature of the neurodegenerative process? What are the things that are causing these cells to die? And so we literally were looking at cells under microscopes for, more than 20 years, 30 years of overall lab work at looking at the molecular biology of this. And so we had, what drives this? And you can actually measure the molecules. And so the question was, why do you have these? How do we now take what you see in a test tube? And then, of course, we worked with fruit flies and we worked with transgenic mice. And then how do you now bring this to human beings? Well, we could see that there was an overall pattern, this beautiful signaling of amyloid precursor protein, which is APP. That's the stuff that's the parent of the amyloid that collects in the brains of patients with Alzheimer's. And you could now see what is changing that balance. What is causing it to be on the synaptoblastic side? What is causing it to be on the synaptoclastic side? And I was just surprised to see, oh my gosh, you can trace this. Literally, here's one of many, many examples. Your estradiol level. Estradiol comes into your brain, goes inside the cell. It binds to the estrogen receptor, which is inside the cell. It drives it into the nucleus. And of course, it affects hundreds of genes. And guess what one of those genes is? It affects APP. So it produces something where what's called the alpha secretase comes out and cuts your APP to make two synaptoblastic peptides that say, hey, your brain is doing well. Go ahead and make new connections and keep new connections. Now, you can see immediately if you drop your estradiol too quickly, which is what happens when you're young and you have an oophorectomy, just as epidemiologists have shown us from the Mayo Clinic, if you drop your estrogen with an early oophorectomy without HRT, you double your risk for Alzheimer's. Well,
I'm also wondering now if birth control pills, which are endocrine disruptors and really shut down the brain-body crosstalk, I'm wondering if we get a small amount of that action similar to an oophorectomy, but it's done by pharmacologic intervention.
It's a great question because, as you know, you got both the pro and the con because you also have an estrogenic effect. So, and I don't know, I have not seen anything. And again, I would have to defer to Dr. Anne Hathaway. She's an expert in this area.
I'd love to talk with her. I might have to have her on the show, but there's a lot of work about not being able to have good decisions or hold on to relationships. Anyway, we can get into that a whole nother time. But what I love is you're talking about, you saw the bigger picture. And somehow medicine just keeps narrowing and narrowing and narrowing and wanting to find one bullet of a drug, and you started out by looking at the cause and then looking for the bigger picture of this. It's actually, what you're saying is so brilliant. It's quite extraordinary. I hope that you're going to be getting all kinds of awards and recognition, and that your work gets utilized so that people don't feel like they have to lose their loved ones. My mother ended up the last few years in a lockdown dementia unit, and I went and lived with her in the bed with her for the last 9 months. Yeah. And
this is so common. It's just horrible. So, there is a lot we can do about this. And, so far we've had lots of pushback. So, and not getting accolades, getting arrows in the back right now. It would be nice just not to have those. But, I understand it. We're saying everybody else is wrong. We're saying all the previous attempts to treat this with monotherapies was wrong, was misguided, misunderstanding what the disease actually is. So no surprise, the people who are pushing that are angry. I get it. But this happens in medicine. This happened, as you know, with vitamin C. People poo-pooed that for a while, hundreds of years ago with scurvy. People poo-pooed the whole idea with Dr. Ignaz Semmelweis, who says, no, you really have to keep your hands clean when you do a delivery, because this is why women are dying with sepsis. The germ theory wasn't there yet, and people said, no, that can't be. So this is no different. We'll get there. It's going to take publishing some more series, publishing more anecdotes as well as clinical trials. But it's clear that this is the way. It's not just about attacking one tree. This is a forest. Now we can see the forest. So let's deal with it that way instead of keep saying, which tree do we have to cut down here? No, it's a forest. And so, the model tells us a lot about what this disease actually is and how to deal with it.
So August 18th, you got to imprint that on your workable, delicious brain cells. August 18th, August 18th, August 18th, because that's when this amazing book that you really must get is called The End of Alzheimer's Program. His first book was The End of Alzheimer's, and he is really helping you keep your loved ones and keep their memories. And I want to ask you one last question as we're tying up. I think everyone is dying to know what you eat for breakfast, lunch, and dinner now that you know everything that you know to keep your brain healthy.
Well, it's interesting. And our daughter, who is a brain health coach, actually, Tess, is much better than I am. She's from the generation that's saying, you guys were crazy. You guys used to eat pizza and stuff like that. And so when COVID started, I started doing more chronometer for myself. I said, I want to see where I stand. And I did find I was not having enough choline. I found out I was not having quite enough protein or fat, and I was too high on the carbs, as so many Americans are. So I've gone to very much what we publish in there, KetoFlex 12-3. That is a plant-rich, this is what seems to work best for cognition, a plant-rich, mildly ketogenic diet that includes fasting periods of 12 or more hours between ending dinner and starting breakfast, brunch, or lunch. So I typically end my last meal around 7:30, and I don't have my first meal. I haven't had it yet today, so I'm going to have my first meal typically at noon or so to get myself this time-restricted eating, as it were. And then I try to confine my eating to about 8 hours, which many people do now. And I try to do a high good fats, avocado. I have salads, things like broccoli. Love broccoli because it also is great detoxer, things like that. But I do have some meat, and I do have some grass-fed beef, and I do have some pastured chicken, and I do like pastured eggs, which give me some good choline. Of course, you can also get it with organ meat. You can get it with things like that. And you can even get that from things like peanut butter, although I don't do well with peanut butter, but some people do, and that's another good way to get choline. And there are multiple other ways.
Is soy high in choline? Is soy high in?
I believe it is, but I'd have to look it up to be sure about soy. But a number of and even some seafood and things like that. And then, of course, another big one is iodine. So many people are low on their iodine, and so having some sea vegetables. I actually take a kelp supplement for that reason, because I'm low in iodine otherwise. And so that's kind of the general plan that I've been using. But it's still evolving, because I'm definitely not as good as my daughter or my wife, who does much better.
Well, you're a guy. You're a wonderful scientist, but you're still a guy. No,
I am still a guy. And, every once in a while I say, hey, okay, get me some grass-fed steak. I want to have some of that. And so, it's overall, I think, you have to get the feedback. You have to see where you stand. And so many people just say, there's nothing I can do. So I'm just going to do anything. I'll go ahead and, have obesity, be in poor shape because, hey, everyone knows there's nothing I can do. And nothing could be further from the truth. We really have tremendous ability to help ourselves and a tremendous ability to lower the global burden of dementia.
We have been speaking with Dr. Dale Breseden. He gives us hope to how to caretake our brain, how to prevent degeneration, and how to even treat neurodegeneration. So the book that's coming out August 18th is The End of Alzheimer's Program. And he just talked about feedback. So if you love this show and information like this that you really can't you just can't hardly get anywhere else. Conversations where you're getting into the nooks and crannies of the information. Please go to drlindseyberkson.com. There's show notes at the bottom of each show, and there's exact steps on how to leave a review so that other people will learn about this life-saving information. You should be sending out this podcast and the show notes to everyone you know and everyone that has aging parents and everyone that has kids and wants to protect their future. Thank you so much for being on the show. And really, your work is extraordinary. And I'm honored that you're back on the show again. And I wish you all the best with your brand new book. It should be another bestseller.
Thank you very much, Dr. Berkson. Please stay safe, everybody.
Okay. Bye-bye.
All right.